in clinics that have implemented this process. So does have some impact, very minimal cost, and again, we need to start looking at weight management, and everybody should be having some weight management programs with the new regulations on offering diabetic prevention programs. I think this is going to become a more important item because it will be April 1st it started. So you all hopefully have that. This is a difficult slide to read, but it's about smoking. We actually measure smoking prevalence, as does everybody if you participate in the CAP survey. And you're a health plan, it asks what percentage of your people smoke. It actually asks the members. If you go back to 2010, and you probably can't see this, our smoking prevalence was 10.2%. We're now down to 7.7%, and I'm getting the 7 minutes here, so I'm going to go fast. What's a little disturbing, that's a large decrease, about 2.5% over roughly 8 years, 7 years, which is a huge, it's a tiny percent, but it's a huge number of patients. When you've added up over 3 million members and you've dropped to 2.5%, somebody can do the math. The state of California has been relatively flat, which is what that bottom curve is. So I don't know if our members who smoke all went to other health plans or we actually reduced things, but we've put in a lot of effort in terms of we measure rates of giving medications, rates of in consulting with patients and counseling them on smoking cessation. We've been really pushing this for years. I think this has a major impact from a public health point of view. Hypertension control, and I was interested in those slides that Hector was showing, when not showing much of a change. This is actually reasonably, I don't want to say easy, but this is very doable. We went from a 50% control rate up to 84% in a relatively short time of 6 years. I think this is doable. It's easy to say an integrated delivery system, everything's easy, but the fact is in 2004, we weren't doing well at all. And there are changes. It's really about systematizing the care, having standard treatment algorithms, holding people accountable, measuring results. We put a little financial incentive on it, having some case managers work on these patients. What's more important, though, than the control rate is the identification rate. And you'll see on this slide, we started with 200,000 hypertensive patients, and 6 years later, we had 400,000. Now, our membership grew, but it did not double in 6 years. So we were underdiagnosing hypertension, and delays in diagnosis, misdiagnosis is a passion of mine, but I think we need to start thinking about, do we actually identify all the cases? I would submit that from a cardiovascular mortality point of view, it's probably more important to identify the patients and look at that rate, and that's had a bigger impact in our system. The control rate in the undiagnosed hypertensive is 0%. Hope that makes sense to people. I'm going to actually skip a lot of this stuff because I want to give other speakers. Nonetheless, I'll just say putting people on statins and aspirin with simulated mathematical models works incredibly well. You can cut disease down by half over a long period of time and save a lot of money over 20 years. But I want to make sure that we've got time for dialogue and questions, so you're going to miss a lot of this stuff. It's all, the key is have a system in place to put people on statins who need to be on it, treat hypertension, identify it, and have a systematic approach. And if you do that, a lot of the details tend to not matter as much. Thank you.
So thank you, and good afternoon, everyone. And I'll be here only for 5 minutes, so I think we'll be on our way soon. But first of all, on behalf of Rees-Stealy, I just want to thank CDC and Dr. Janet Wright for the Million Heart recognition we received. So our physician, pharmacists, nurses, staff, and leadership are very proud of this. Just to share, a few years back, we were close to around 70% control, and now today, the latest numbers we have is that almost 82% of patients have a blood pressure in control. On this journey, I think we have been, if you think about it, this is truly population health, just moving patients, this 10%, 12% improvement. We have almost now 21,000 patients who are in control, and as Dr. Kanter was mentioning, this is, you can really shift the care for a large population in a system. Having said that, on this journey, we have been really beneficiaries of many of the national and statewide programs, all the way from Measure Up, Pressure Down, and the Right Care Initiative in San Diego, and also the CMMI's grant, which we received in San Diego. So it truly takes a village to raise a child. So we were a child, and I'm really appreciative of all of you in this room, thanks to your efforts that we have been able to improve our grades. So I just want to share a few of our learnings quickly. This is from our San Diego's CMMI grant, which we ran for almost 3 years, and we had 4,000 patients who were really uncontrolled with blood pressure and had high cardiovascular risk. And I just want to show how the systemness happened. And so on the top, we had patients who, I think this is, so I think on the top, we have patients who are blood pressure not in control or high ASCVD risk score. And I think we heard from Dr. Shortrill that we need to risk stratify patients, that these are the ones with ASCVD risk score more than 7.5%. On your right, many of those patients who are uncontrolled, we offered them wireless blood pressure cuffs at home or texting program. Almost all of our this group of cohort received health coaching, lifestyle modification, and really focus on medication adherence, which was Dr. Duddle's medication bundle. We have now renamed that bundle as Dr. Duddle's bundle, So I think the four. And we also had pharmacists, in some of our groups also had pharmacists trying to review patients who were more than 3 antihypertensive medications. And then always trying to communicate back with the primary care physician or the treating physician, whether it be cardiologist or nephrologist. And the whole goal was to really try to activate the patient. I think we heard from Dr. Wright about activation, and this is really to make it a sustainable program. We have to get the patients activated towards long-term outcome. So this was creating the systemness. To share some of this allowed, this innovative project allowed us to really test out some of the things like wireless blood pressure cuffs in our community, trying to give some smart wireless pill bottles. We also did some digital pills where people, when they swallowed the pill, we would get a text message that they really took the medications. So just any of you who is going to try this, I just want to share one learning that all these gadgets are cool, they are nice. Their purpose is for education, and once they are done and you have the patient activated, they're supposed to return it back. Unfortunately for us, many times patients just held on to this, didn't want to return this, they just started loving this smart wireless pill bottles which were ringing, chiming, and changing colors, So I think, so that's that, but I want to share some of the data if you're trying to do wireless blood pressure. This is for people who are really difficult to control blood pressure, like 180, 160 average. You can see the average blood pressure was 158, systolic for this. And when we studied this and we provided them as wireless BP cuffs, and then we took them back wherever we could, and then 6 months later, still patients had a good control of blood pressure. So to your earlier point about home blood pressure monitoring and wireless blood pressure, and I know you have done a lot of work in this, it does help, and I think we support NCQA's, the new quality measure where home blood pressure monitor readings will be allowed to be part of your quality performance reporting. The last slide which I have and want to show is that health coaching does work. I think, you don't really have to have, health coaches come in different shapes and forms and training. We use different kinds of help. Some are medical assistants, some are community health workers, some are pharmacists. But if we were to get them a standard curriculum and train people on health coaching, patients do connect with them. So this is, just to walk you through this slide, this is in our group, patients who received health coaching, and during the grant, remember, these were people who were uncontrolled hypertensives. The control rate for blood pressure was around 81% to 85%, it went in fact as high as 85%. And then once the grant ended, we termed the coaching encounters, and the last blood pressure was 84%. But even 6 months later, we are still tracking this cohort of patients of close to 1,400 patients, and these were uncontrolled to begin with, and they're still maintaining their control rate. So I think there is some kind of positive effect and life-changing effect, and to your earlier point about patient activation, this is boots on the ground experiment. We can show that health coaching does work. So at this stage, I just wanted to share a few of our learnings. I know many of you are trying to implement this in your systems, but these are the few things I hope you can either take back which might support your approach, or you could learn from here and take something new back. So with that, I think I ended very quickly. So thank you very much for your time. Okay.
We're very grateful at this time to welcome to the stage one of our co-founders of the San Diego University of Best Practices, the very first demonstration project of the Right Care Initiative, Dr. Scott Flynn, who's now with Blue Shield and a true believer in this work that we've done together over the years to very significantly reduce cardiovascular events together. And with that, I'll give the microphone to Dr. Scott Flynn, a former Navy medical officer to the Navy SEALs.
Thank you, Hattie. Afternoon, everyone. I'm currently with Blue Shield of California, one of the regional medical directors, and also up here with me is Dr. Malaika Stoll, who's statewide regional medical director, and Dr. Poonam Garakshakar, who is the regional medical director for Northern California. And they're up here for a special reason. We're all here because we believe in this work, we think it's good, and at Blue Shield of California, we think it's a good thing also. If you're aware, there was a recent publication in November about how the heart attack rate in San Diego is dropping faster than the rest of the state. It is related to when the Right Care Initiative was started in San Diego. Now, correlation does not make causality, but one would say, we might pat ourselves on the back a little bit for what we did. So when you look at that, that's a pretty good thing. Okay, so maybe this Right Care Initiative thing actually does work. All right, if it does, that's great. When you look across the state, we have 3 chapters of the Right Care Initiative, San Diego, the original one, and Sacramento and LA. What's the other area that we don't have anything to work on this? It's the Bay Area. Okay, and Blue Shield's headquartered in the Bay Area. And you look around and go, where's our opportunity? So our opportunity is, why don't we get a chapter started in the Bay Area? So along those lines, Blue Shield of California, there we go, is going to partially fund the beginning of a Right Care Initiative chapter in the Bay Area. So we are pledging $125K a year for the next 3 years to get this up and running. And to quote Jerry Penso, who's standing there in the back, when he left the Right Care Initiative in Rees-Stealy back in 2011, Jerry, was it? And turned over the co-chair to me, he said, the Right Care Initiative will either grow its own survivability and because it's the right thing to do, or it won't. Well, not only did it survive, it's now growing. So, thank you all.
So, Dr. Flynn, I just want to thank you on behalf of the School of Public Health and your colleagues. Blue Shield has been a great partner for us here in the Bay Area. We've done work with them, the foundation, but also on the operations side as well. And we like them so much that they're former presidents and CEOs. We hire them at a very low rate to be a lecturer to our students. So Bruce Bodakin, so we hope we can keep up that tradition also. Well, again, thank you. I think we're now going to break for lunch. Yeah. We're going to break for lunch, which I think is outside. Is that correct? Yep, right out here in this way here. And I think we're going to try to speed things up a little bit, so maybe if you can, about a half hour and then come back. Okay. Heidi? Yep.
We will reconvene in this room at 1 o'clock to hear from Dr. Jerry Penso. And for those of you who'd like to get photographs with Dr. Janet Wright, she's going to have to leave a little early today, so we'll try to get some photographs with her during lunch. Okay, thanks everyone.